Now let's talk about renal tubular defects. We have the order, which is the Fanconi-Bagels, Fanconi syndrome, Bratter syndrome, Gitelman syndrome, Liddle syndrome, and all those. So let's talk about each one of them. So if you look at this picture, the Fanconi syndrome. So let's look at the defect. So it is generalized reabsorption defect in PCT. And here they have mentioned the PCT. Generalized reabsorption defect. When you have a reabsorption defect, you have increase in excretion of amino acid, glucose, bicarb, phosphorus, and all substances reabsorb in the PCT. So basically, you can just minimally you can think in Fanconi, PCT is down. When PCT is down, whatever is reabsorbing is going to be not reabsorbed, so it's going to go in urine, right? So what are the effects if the PCT is down? We have metabolic acidosis, proximal RTA, hypophosphatemia, hypokalemia. Again, because you're not resolving anything and they're going into urine, you are going to cause hypophosphatemia and hypokalemia and metabolic acidosis. What are the causes? Why did it occur? Either it is due to hereditary defects, for example, in Wilson's disease, tyrosine or glycogen storage diseases, ischemia, multiple myeloma, drugs, for example, ifosfamide, C-plastin, tenofovir, lead poisoning. Notes: growth retardation and rickets osteopenia, common due to hypophosphatemia, and volume depletion also common. So all we have to know in order of this thing, PCT is down. Let me actually write PCT here so we know that PCT is out. So let's move on with the Bartter syndrome. There is a reabsorption defect in thin ascending loop of Henle. This is the thin ascending loop of Henle. So let's talk about it. We have the metabolic alkalosis, hypokalemia, hypercalciuria, autosomal recessive, and present similar to the chronic loop diuretic use, because again, same thing, loop diuretic also work on this channel and inhibit these channel. So if we have defect in this one and this channel is not working, it's going to give us the same presentation. So just think about this one as Bartter syndrome, right? This is the ascending, thick ascending. Just like loop diuretic. Or you can think ascending loop of Henle. Loop of Henle. Okay, moving on with the Gitelman syndrome, reabsorption defect in Now we're going a little specific here. There was a reabsorption defect of sodium chloride in DCT, not the whole DCT, but just the sodium chloride. So it's going to cause metabolic alkalosis, hypomagnesemia, hypokalemia, and hypocalciuria. And for all of this, go back and look in DCT, and you can easily figure out how we have all of this going low. Present similarly to the chronic thiazide diuretic. Okay, so this one is going to be for thiazide diuretic. Thiazide, just like thiazide diuretic use. Less severe than the Bartter syndrome. Liddle syndrome. This Liddle syndrome is a gain of function mutation which causes decrease in sodium channel degradation, which causes increase in sodium resorption in the collecting tubule. So only one specific thing. You have an increase in absorption in the collecting tubule. So it's going to cause metabolic alkalosis, hypokalemia, hypertension because so much sodium, and decrease aldosterone because this is inhibiting it, leading to decrease in aldosterone. But again, you're reabsorbing sodium at the expense of potassium. That's why hypokalemia. Okay. Autosomal dominant. It presents similar to hyperaldosteronism, but aldosterone is nearly undetectable. Treatment is amiloride. So little syndrome is like hyperaldosteronism, increase in aldosterone, right? And so that you also see the features, same thing when you have increase in aldosterone, exactly same thing what you see here. But the problem is, it's like aldosterone. So in reality, aldosterone is not even there. And then you're like, okay, wow, it's something little syndrome. Then you have the syndrome of apparent mineralocorticoid excess, where the cortisol activates mineralocorticoid receptor 11-beta-HSD, converts cortisol to cortisone, which is inactive on these receptors. Hereditary 11-beta-HSD deficiency leads to increase in cortisol, increase in mineralocorticoid receptor activity. It's going to give you metabolic alkalosis, hypokalemia, hypertension, decreasing serum aldosterone level, and cortisol tries to be same as aldosterone. Okay, autosomal recessive can be acquired disorder from the glycyrrhetinic acid present in the licorice, which blocks an activity of alpha-beta hydroxysteroid dehydrogenase. Treatment is the potassium-sparing diuretics, which decreases the mineralocorticoid effects, or corticosteroids, which are the exogenous corticosteroid, decreases the endogenous cortisol production, decreases mineralocorticoid receptor activation. Again, here the problem is you have a syndrome of apparent mineralocorticoid excess. Cortisol activates these mineralocorticoid receptors, and 11-beta hydroxysteroid dehydrogenase converts the cortisol to cortisone, which is inactive on these receptors. Okay, and then hereditary 11-beta hydroxysteroid dehydrogenase deficiency causes increase in cortisol. When you increase the cortisol, because you cannot convert the cortisol to cortisone now. Remember, cortisol was cortisone was converting to cortisol is converting to cortisone with the help of 11-beta hydroxysteroid dehydrogenase, right? Now, when we don't have this, we can make cortisone. Cortisone is something that is inactive on these mineralocorticoid receptors. So because we don't have this anymore, the cortisol becomes active, because you can't convert it because you have a lot of cortisol now that stimulates these mineralocorticoid receptors, and this causes increase in mineralocorticoid receptor activity. Okay, so what is the treatment to all of this? Well, give potassium sparing diuretic, which is decreasing mineralocorticoid mineralocorticoid effects, or give outside steroids or exogenous steroids that decreases in endogenous cortisol production, because you're giving from exogenous. That exogenous cortisone is going to inhibit at the level of pituitary and also at the level of directly inhibiting the cortisol itself. But that's only the exogenous steroid. So basically trying to inhibit the cortisol from the exogenous corticosteroids. That would give us decrease in cortisol. That's going to cause decrease in mineralocorticoid receptor activation. So here the summary is pretty simple. It looks pretty hard. I think that we have, it looks hard. This page looks hard, but this is not that hard. All you got to know is, first one is the Fanconi. This mnemonic is really good. Fanconi bagels, okay? Fanconi bagels. And once we know the Fanconi bagels, we know the first one, the Fanconi, is the PCT is down. In the Bratter syndrome, we it's just like loop. If we're talking about something like loop diuretic, we also, it's not fair to just talk about loop and not talk about thiazide diuretics. So, okay, Brador is the loop diuretic, and the Gitelman is a thiazide diuretic, okay? And when we talk about all of this, we should mention that aldosterone plays a really important point in all of this things, right? So little X-like increase in aldosterone. And syndrome of this actually by the name you can just get it. The syndrome appear in mineralocorticoid axis. How can you have a mineralocorticoid axis where there got to be some mutation or some hereditary inhibition of something, some enzyme, so that you have access of mineralocorticoids, right? If you're going back to your endo, you see that big nice graph, the picture thing, you know that you have to cut down some enzyme to go on just towards the mineralocorticoid. So which enzyme is here? It's 11-beta hydroxysteroid dehydrogenase. That causes increase in cortisol, which activates the mineralocorticoid and causes all of the increase in mineralocorticoid receptor activation effects. That's pretty much all we have for this one, the renal tubular defects.